Moving on to the next bite size, which is from Nia Davis, Service Manager of Cynhadledd University Health Board, about virtual nursing. So, okay.
Hi there, good afternoon. Pnawn da. My name's Nia Dennis, and I'm the Clinical Nurse Specialist for Dermatology in Cynhadledd University Health Board. I'm just going to share my screen with you now. Bear with me 2 seconds. Can you all see the screen there?
Yeah, we've got the screen there, but
Yeah.
we've got the show down the side as well, but that's fine.
Okay, hang on, I'll try and... Okay, sorry, I'm gonna have to do it this way. It won't let me share the other way. Okay, sorry about this. So here in Cynhadledd, we envisaged and wanted to do virtual nursing for our acne patients, and this to help the delivery of integrated health and care services in rural health Wales. So myself and Catherine Rusconi then helped set this up. So why we introduced virtual acne clinics. It all came about from the COVID-19 pandemic. It brought significant demands and pressures on the health service, and improvement in technology brought much needed relief. And it instigated virtual clinics at a time when staff and patients were isolating, outpatient departments were decreasing their footfall, and people were in a period of influx and uncertainty. So our objectives to maintain the acne service throughout the COVID-19 pandemic. It was to prove a to provide then a gold standard service and reaching out to acne patients of all areas of Cynhadledd University Health Board, and to manage and reduce waiting list times, because during the pandemic these were creeping up. Pre-pandemic acne clinics. So prior to the pandemic, acne patients would be seen via traditional methods at the face-to-face clinics with a doctor in either Glangwili General Hospital in Carmarthen or Prince Philip Hospital in Llanelli. So clinics were not offered pre-pandemic in Pembrokeshire or Ceredigion, and patients were expected to travel here in Glangwili or Prince Philip for the treatment. So we wanted to provide a positive patient experience and consideration of their needs, considering the long distances they had to travel to the acute hospital sites for clinics, time taken out from work, school, university, and so on. So we came about with the initiation then of the virtual clinics. So during the beginning of the pandemic, as previously said, the outpatient footfall was decreasing, and only urgent emergency care was being delivered in the face-to-face outpatient clinic. So we felt this was compromising care where the patients were already established on acne treatment and needed continuity of care for them to complete the medication course, especially for those already established on treatment as the pandemic developed. And also we were following the BAD, which is British Association Dermatology 2020 guidelines were applied. So just for you to understand, there is a treatment acne pathway then. There is a male version and the female version. So the males then that we reviewed in clinic every 6 to 8 weeks, and this is to maintain that continuity with them, that they are compliant with their treatment, to see what side effects they're experiencing, and also to assess the mood changes which can come about from the treatment. And then blood monitoring is also important. So for the males, it would be routine pre-screening, then at 6 weeks, and then every 3 monthly whilst on treatment. Whilst all this is in place and everything is smoothly, we were then able to prepare prescription to be generated from here in Glangwili, and they would be dispensed then in the hospital pharmacy of the patient's choice, so depending where they lived, which would be Withybush, Bronglais, Prince Philip, or here in Glangwili Hospital. So the females pathway is slightly different, where they need to be reviewed every 4 weeks, and mainly being because we need to do the HCG pregnancy testing monthly. Some trust did put in place urine pregnancy testing, but we maintain the gold standard here with monthly blood monitoring, HCG testing. So again, we would check compliance, side effects, and assess mood changes. If any creams or ointments were needed from the clinic, we were able to prepare then GP advisories for the GPs to prescribe these. And again, the routine bloods for the girls are slightly different, whereas we do it at 4 weeks, and again then every 3 months whilst on treatment. And same with the boys. Once this is all established and in place, the preparation of prescriptions will be generated at the hospital and pharmacy of the patient's choice. So setting up the virtual clinic, so despite the pandemic, the dermatology waiting list was steadily increasing. Decision was made to continue care virtually via telephone originally, whilst we were setting up the virtual platform. So with support from the service manager and myself, we set up a virtual nurse-led acne clinic for the established patients originally. This involved collaborating as a team, adjusting pathways, utilising technology, and improving the patient experience, meeting the patient's needs. Then, as time went on, the decision was made to set up and use Attend Anywhere virtual platform for our clinics, and dermatology was prioritised for one of the early users of Attend Anywhere. So once we established the acne clinics with Attend Anywhere, the virtual clinic provided and proved such a success and resulted in reducing waiting list times for the acne patient. This then allowed us to broaden our scope of practice and allowed us to offer video group consultation for the initialisation of acne treatment by offering that group consultation, and where we can advise and counsel the patients pre-acne treatment. So the group virtual consultations allow patients to be counselled and learn about the treatment prior to commencement of the medication. So they get the counselling for the pregnancy testing and that they need to be on contraception for the girls. So we do a male and a female consultation groups. And it's also had the added benefits for patients to share experiences with each other, so they don't feel alone when they're suffering from this skin condition. Also, some patients may be going on this the second time, so they were able to share their experiences of how it was for them during the first time and give tips and everything to each other and what helped them through. So, and also we've ended up doing virtual clinics for biologic treatments as well. So the success of using virtual clinics has been amazing for us here in dermatology. We feel it's been an excellent example how a service can succeed in the peripheries with all the difficulties of the pandemic, and by adapting working practices and effectively utilise the workforce available.
My payslip keeps on coming to my very original.
Oh, hello?
I don't think that was working terribly well. Yeah.
Hello, can you
Hello,
can you hear
Nia.
me? Hello,
Yeah.
yes,
We can hear you, Nia, now. Yeah.
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 Okay, could you not share
Great.
the?
We heard. Thank you. Yeah. Then we
Okay,
had a bit. Yeah. Was that the finish of your presentation, Nia?
the success. No, so hang on. So yeah, the next slide then is the end, and thank you very much for your invite and opportunity to present our paper. So any questions?
Thanks very much, Nia. I'm being a horrible chair, not allowing questions because we're running a bit tight on schedule, but we will take your contact details and forward questions to you if we may.
Yeah, that's fine.
Thank you.
Very
Thanks
much.
very much, Nia.
Yeah,
Thank you.
thank you very much.
Great. So now we move on to David from eMERTS Cymru, who's going to give us a talk on paediatric cardiac.
Thank you very much. So my name is David Rawlinson. I'm a anaesthetist by background, but I work for RHCW and Wales Air Ambulance as my full-time job. Today I'm going to be presenting on behalf of a team of people, but particularly Sean Jenkins, who is joined remotely. So she might be able to dip in towards the end. And Professor Owen, who paediatric cardiologist in Cardiff and was the kind of founder of paediatric telemedicine in parts of Wales. So you might wonder why someone from the air ambulance or EMRTS is talking about telemedicine. I've obviously had a chance to play around with it this morning on the robotics, which was quite interesting. My day job is managing this service. We have the 4 air ambulances across Wales. We have the rapid response vehicles, and that's what we do. The reason I got involved in the telemedicine was just before the pandemic. We had an opportunity to explore the use of satellite technology in rural parts of Wales to support healthcare. So we received a £57,000 grant from the UK Space Agency just to look at how we could improve connectivity, because our teams travel across Wales. They end up in places with no broadband, no 4G signal, no 3G signal, certainly no 5G signal. So we were looking at testing that essentially. So it started off just before the pandemic with a few of us driving around in this van, which had a Ka-band satellite on the top of it. We worked with health carrier services, and we essentially went to everywhere that we knew there was no phone signal and no internet connection, and we tried to transmit medical data from those areas. So in terms of our air ambulance stuff, that's actually just pretty basic stuff. Voice is all we need, and text. We just need to communicate updates on patients and location. That's not much of a challenge. You can do that with satellite phones. You can buy them on Amazon. You can do that. But what we really wanted to do was to find something that could really test the technology. And so the best thing we found was live ultrasound images from paediatric cardiology cases. And we're talking about neonates, so very, very small hearts, very small vessels, but very high frame rate requirements when you do ultrasound. So just before we did that, I spent a bit of time driving around Wales. I already drive around all of our sites from time to time, sometimes fly around with them as well. You can kind of see the connectivity we get, and essentially with the technology we had with the satellite combined with some other technology we developed with the company, Tactical Wireless, we were able to guarantee coverage everywhere that we went in Wales, including places with no phone signal. So that was really positive from that. But that brought us on to that worst case scenario. You know, you're never actually going to do this. You're never going to stream a baby's heart from an ultrasound from a place with no phone signal. But if you can do that, you can do anything. It's kind of the worst case scenario. We got the grant towards the end of 2019, and then obviously the pandemic hit and everything changed for everyone. So, you know, for me, that meant our service activity dropped a bit. My work in hospital as an anaesthetist paradoxically reduced, so the elective work had been cancelled. So we started supporting parts of the pandemic response, and some of it was supporting the remote testing centres in South Wales, using the satellite and the cellular technology. But then because we had already started this project and we already had the kit, we started engaging with hospitals and looking at paediatric telemedicine, because all the outpatient clinics are cancelled. And during that time, babies are still being born, still have congenital abnormalities, still needed urgent scans, still needed follow-up.
Oh,
after
how
surgery,
lovely.
etc.
Thank you.
So we conducted a project, and we involved all the units in South and Mid Wales. You said, yeah, can you put your camera up, please? You could reshare it if you want. We love technology, don't we? There we go. I'm taking back control. I feel for the team here because we did a conference a few weeks ago like this, and I had exactly these issues. So essentially, there's, from paediatric cardiology point of view, there are only 4 or 5 consultant specialists in Wales, and they're based in the centre in Cardiff, and they're also up to in Cardiff and Bristol. So clearly for the rest of Wales, in terms of those cardiologists seeing patients and scanning patients, it's quite a challenge. And for years they have been travelling to the sites, but they've also been doing telecardiology as well. And the key is, in each of these sites, you have highly specialised sonographers who are technically able to do the scans, but you need the consultants with the specialist knowledge to be able to make the diagnosis and make the clinical decisions. And this isn't just elective stuff. This is also emergency cases. So it could be 3 o'clock in the morning. At points before we've done this project, the consultants will be driving from Cardiff down to Glangwili to do a scan. That's 1 to 2 hours drive. In that time, the baby's actually needs treatment. So we've changed that to be able to go from that 1 to 2 hour drive to immediately opening a laptop in their house, having someone locally scan the patient, and then make diagnostic decisions. And we'll go through a couple of those shortly. Seeing the robotic stuff this morning is really interesting because that's another way of delivering it, and it would fit quite well with this. So during the period of the project, a number of things happened. So it wasn't just the consultations, it wasn't just the scans, it was also teaching, it was job interviews, it was outreach ward rounds, surgical ward rounds, weekly teaching sessions, and also with the congenital abnormalities, while the mothers are still pregnant, being able to do those scans and then counsel the mothers, and they can be in their local area. So they could be in Glangwili or Singleton, with a consultant sitting in UHW, and actually that improves, the reach, but also tackle some of those challenges around travel, because it's quite a long round trip, and parking's a nightmare in the Heath. So over the period of the projects, the 7 months, we conducted 32 live consultations with real babies, real patients. A number of those were emergencies, a number of them resulted in life-saving decisions, i.e. do you keep them in the hospital, or do you transfer them to one of 2 other hospitals, so Great Ormond Street, Bristol, Alderhay. That's kind of where my involvement comes with the air ambulance, because we then sometimes affect those transfers, but you need to make the diagnosis and decision. There's no point in having a helicopter until you know what you're doing with it. So we did a case series of consultations. One of the key differences from the old technology was an old Polycom system, which had actually completely stopped working pretty much. It had a VHS recorder attached to it, and the new ultrasound machines didn't work with the technology. So we introduced a product that we co-developed, which essentially connects any ultrasound machine to any laptop. You don't need to install anything. It works without drivers. It works on NHS laptops. It costs about £1,000 compared to £20,000 for the old Polycom equipment. And essentially it allows you to stream images over Teams. You could do it over Zoom. You could do it over any package. At the time we were using Skype and Polycom, but since the kind of advent of Teams and everything, we've been able to do it over that. And of course, then it's all secure within the NHS network. Just a few screenshots of what we're doing. So these are live scans. You get me looking peculiar into the thing, the Sean there, looking into the monitor, but essentially we're able to stream live scans or saved scans as well of these babies. So the overall project, we've written it up. It's gone for peer review. It's going around a few other rounds, but we've made it freely available as a preprint online, which you can scan the QR code or we can email it around. But we've got this case series detailed in there of 32 patients. We've estimated £200,000 of savings just in the technology in South Wales. And we've got NHS England who are about to purchase for parts of London and Devon. And then we've also had kind of other interest from different areas as well. Sian, are you there at all?
Hi, David.
Hi there.
I don't know if you can hear me.
Might need to, is there a volume?
Can
We
you
can
hear
see
me?
you and hear you.
Great. Thanks very much. So you've explained really well how this process came about, and it's really revolutionised how we, work with the team. So I'm a general paediatrician in Carmarthen in Glangwili, but I have an interest in cardiology, and I've been fortunate to train in sort of echo imaging, and so we run murmur clinics and work very closely with the team in Cardiff. And so we're still using this technology. David's been through the case series that we did to sort of test it, and we're still using it. So just recently, I think David's got a slide there. For example, a couple of weeks ago, baby came into the ward acutely unwell, initially sort of thought to be sepsis, but transpired to be a cardiac. So when I was asked to see this baby in clinic, very quickly realised this was a undiagnosed coarctation who's actually in failure and becoming more unwell. So immediately got the telemedicine kit, was able to contact the on-call consultant in Cardiff, who spoke to Bristol and then facilitated the immediate transfer of this baby for emergency surgery in Bristol. So that's one example of how we use it. Another is, for example, babies who have had surgery in Bristol and need a follow-up scan, but whose family have any difficulty travelling. We're able to do, the consultation, but with the cardiologist from Cardiff in the room virtually, up on the screen, but able to see the live echo. And it's, the patients are really appreciative of the need of travel is not there anymore. They're able to get the expert care. So it's been a fantastic system, and I'm quite excited really about the future and how this can be rolled out to other areas perhaps. I'll hand back to David. Thank you.
Thanks, Sian. That's good. So yeah, in terms of the kind of next steps, so we do want to formally evaluate this. We've approached Tech Cymru. They haven't got any capacity to do it at the moment. We've approached RHCW. We are looking for someone to formally evaluate it. Also, it's not part of my job at all. I love it. It's really interesting. It's a really good application of technology, but there is no owner for this at the moment. It's really difficult with these cross-border things. It's every health board in Wales is impacted. I can't do it because it's not something we're commissioned to do, but I'll keep doing it in my own time because I can see real benefits. But I would like an owner for it, and that's what I keep asking anyone that's interested. Ideally, an NHS Wales owner. We can do demos. We nearly did one today. We don't like doing live demos. The robotic one earlier was quite good, but it's always a risky thing to do. It's in a live audience, but we can do that if we've got a bit more time. And also we've had recent interest in podiatry. I had no idea podiatrists use ultrasound, but they do in AB Health Board. They're starting to roll this out for supervision and training of their podiatrists. There's previous work from the company worked with around stroke diagnostics, and that came from the kind of Scottish Islands and things. So there's definite things there, especially with the thrombectomy side of stuff within NHS Wales. I think there's huge benefit there. And then obstetrics as well, there's quite a lot of interest. But again, there's no person to say who's going to do it for all Wales. It's really cheap to do this. It doesn't cost much, and that's the difficulty. It's not a multi-million-pound programme. It's just finding someone who can do it. And I'd rather do it centrally than to let everyone do it separately, because that's where it becomes a nightmare. And actually, the biggest part of this learning was the technical support and just, having a single point of contact, someone who knows the technology and knows the clinical side of it, and some kind of on-call rota to support people, because at 3 o'clock in the morning with a baby who's blue, you don't want to be worrying about if Teams is working or not. You just want to be able to get on the phone and get it to work. So yeah, and we just got to acknowledge some of this was funded through charitable donations through the UK Space Agency as well. And then there's a huge team of people that worked on this over the past year or so, and the previous work that goes back 20 years as well. But the paper's available through the QR code, and we can email it out after the conference if anyone's interested in that. Thank you.
Thanks, David, and I'm glad your laptops were more reliable than ours a bit today. Right, and now we have the final bite-sized presentation in this part, which is from Vicky from Betsy Cadwallader. Is Vicky on? Yeah.
Hello.
Oh, yeah. Maria, you have your camera on your laptop. If you could turn it off, you won't be broadcasting to all of us. Thanks, thanks, Maria. Vicky, over to you.
Thank you. Can you hear me and can you see my PowerPoint presentation?
Yeah.
Fabulous. Okay, so thanks for asking me to talk. I'm going to talk about developing a digital remote heart failure monitoring app. I work up in Betsy Cadwallader University Health Board as a heart failure A&P and echocardiographer. So first of all, why heart failure? Well, it's the only cardiovascular disease with increasing prevalence, and it's relatively expensive to the NHS, accounting for 5% of all admissions, 2% of the overall budget, and it's got really poor quality of life, and with around a 30% one-year mortality rate. So effective treatment and management requires patient empowerment through education and support and encouraging that self-management, as well as optimization of medications. So what do I do? My service looks at upstream management of the heart failure patients. So we're a community-based service, and we manage patients both early on in their diagnosis to get them on to the right medications at the right doses, because we know that prolongs life and improves the quality of life. But we also look after them towards the end of that journey as well. The aim of our service is to avoid hospital admissions and facilitate discharges. And I see any adult with a diagnosis of heart failure with reduced ejection fraction and deliver that education about the condition, symptom management, and titrate their medications and manage any decompensations where patients with heart failure decompensations fill up with fluid. So who have I worked with whilst developing this remote monitoring app? So I worked with my counterpart, Mandy Welsh, in Cynhadledd Health Board, Life Science Hub Wales, and Humour. So Humour were awarded a funding grant from the Welsh Government so that they could work with a health board in Wales to develop nurse-led virtual care during the pandemic. We wanted, during this pilot, to look at if we could safely optimise medications within guidelines proactively to avoid admissions for our really vulnerable patients. A lot of our heart failure patients were shielding during the pandemic. And my area is a particularly rural geographical area of Wales. So travelling is challenging at the best of times, but during a global pandemic is even more difficult. And a lot of face-to-face clinics were suspended, and staffing capacity was increased during the pandemic. And I was actually redeployed and was really concerned about keeping an eye on my heart failure patients during that really challenging, unknown, evolving time. So we wanted to assess if remote patient monitoring can safely, proactively manage heart failure patients. And the heart failure patients on the Humour app recorded their symptoms and vital signs, and the clinicians looked these up on their dashboard and decided what next steps to make. So the top two pictures are an example of what the dashboard looked like. So on the left-hand side, you'd go onto your main dashboard, click onto a patient, and you'd have these boxes. And the top right-hand picture is an example of if you clicked on one of those boxes. So, for example, the matrix relating to blood pressures, you could see overall trends as well. And the bottom box is an example of what the patient's view would look like. And I've put these up specifically because I'm not a tech geek, and I was a little bit worried whether I'd wonder what I got myself into when we had this app in creation, whether it would be clunky, difficult to use, counterintuitive. And I was absolutely delighted with how easy it was to use, how intuitive, user-friendly, visually, aesthetically pleasing to use. It was really made it quick to have a look and see what the trend was with your patients. So the report showed really positive results, and interventions that we managed to highlight, specifically because of using this remote monitoring app. We were able to identify deteriorating patients early and change the management to counteract that deterioration. We were able to facilitate early discharge and get patients titrated, so on the right medications at the right dose, faster. We were also able to instigate investigations because of what we could see on the app. So, for example, with that, one of the patients during the pilot, we could see they were bradycardic. So we were able to instigate and organise an ECG. And from the results of the ECG, you can look at reducing medications or even look at referring up for devices. And patients that were included in this pilot were unstable high-risk patients, acute discharges, and worried well. So this pilot got quite a bit of media interest, and there was a BBC News piece. And one of my patients who had been discharged quite a while ago from my service phoned me up and said, you know, I'm meant to be being followed up by my cardiology consultant, but because of the pandemic, all of those appointments are cancelled. I'm really concerned that nobody is keeping an eye on my heart. Can I please be involved in this pilot? So basically, I onboarded him onto the pilot. So it was a really good example of reassuring worried well to reduce demand on already stretched clinical services. Everybody was stretched during the pandemic, and primary care was stretched. So we were able to reduce those patient contacts. So this project was able to demonstrate that digital intervention can support our complex older patients. We had extremely positive patient and clinician feedback and experience. We were able to improve and proactively manage enhancing patient safety, as well as provider capacity. And it was recognised widely and has enabled new opportunities to transform care and research. Patient feedback has been really positive, as I said. So 9.7 out of 10 patients said they were highly likely to recommend the app. Patients found it really quick and easy to use, and they could see what was going on with their care. They felt reassured knowing that their heart nurse specialist was keeping an eye on them. All the patients agreed that the app was helpful in improving communication. Patients said it was really easy to use. And the picture there is from the internet, from BBC News, and that was the internet sort of publication of the interview that we did. And one of my patients that I looked after and managed to avoid quite a few hospital admissions with him. And it's my favourite quote where he actually said, "This is the best app on my phone." Clinician feedback was also extremely positive, and they fed back improvements in patients' understanding, patients' engagement, enabled clinics to run more efficiently. They said it was easy, intuitive to use, supported their ability to identify deteriorating patients at a glance. They discharged patients early because they were able to closely monitor them on the app. Clinicians were able to start interventions sooner than they otherwise would have done, and this led to avoided hospital admissions. And they also said how patients reported that that they could see their signs and symptoms improving, and it helped them to understand how taking these medications, often that have quite unpleasant side effects, were actually helping them in the long-term management of their condition. So it improved care, enhanced patient safety, as well as provider capacity, faster optimization. So examples are that patients were able to be optimized onto their 4 pillars of heart failure medication within 4 weeks in some examples, rather than several months, specifically because we were able to use this app. Admissions were avoided because of proactive care, that early discharge, about 75% reduction in overall time of optimization with the medications. 10% of the cohort of patients we were able to avoid admissions with. A 19% reduction in outpatient attendance, and that's not DNAs, that's they didn't need to come in to face-to-face consultations over the 6-month period. 5% of patients from the cohort were able to be discharged early, and 82% of cases were escalated because of this app. So just to finish off with then, I wanted to put this slide up just to summarise my journey to go live with the heart failure app. It's been a really long and winding road. I am not a nurse researcher. I came into this very green, and it's been a massive learning curve that has been exciting, frustrating, exhausting, satisfying. And what it's been, I feel it's really important to sort of share for other people like myself out there who might have a really good idea but are quite novice with research. I found it's really important to find my key stakeholders, surrounded myself with the people who can make this happen. I couldn't have done this on my own. As I said, I'm not a tech geek, so I certainly couldn't develop the app, but I also needed to make sure that I was doing what my health board wanted as my employers, that I was working, according to their requirements. I had to figure out funding. We had to make sure we had the right matrices in place. So yeah, it's been a really long and winding road, but really rewarding as well. Thank you.
Thank you very much, Vicky. That picture of that road probably looks familiar to certain people who tried to get stuff off the ground in other. I'm sorry we haven't got time for questions, but if we may, if people have questions of any of the presenters, we will put them in contact with you so that you can speak to directly. So now it's time for the next breakout sessions. I'm assured that the breakout room upstairs over there is working now. Famous last words. I am holding onto wood while I say that. So I will give you a few minutes to get to the breakout rooms you wish to attend. Breakout 2 is upstairs, breakout 1 downstairs over there, and this is the main room here. Thank you.
Just that one, is it? To click? Let's start it now. Okay. They're all on now. Okay. Okay. Afternoon, everybody. Okay, I'm Nigel Rees, Head of Research and Innovation for the Welsh Ambulance Service. I'm here to present today a project we've been doing around the use of drones in emergency care and to deliver blood products. So when I was driving up here, it was quite a lot of interesting reflections going through my mind. I mean, started working here over 30 years ago. In 1989, I used to work in the local ambulance station, which is now a housing estate. And you can hardly imagine an ambulance service today without a defibrillator, without paramedics, without any drugs, any pain relief drugs. But that was the world that I came into 30 years ago. And it's through technology, education, innovation that has brought us to the stage of where we are today. People like David presenting on helicopter emergency medical services and the whole vast range of technology that's allowing us to transform our practice. One example is the use of defibrillators. As I say, we didn't have a defibrillator on an ambulance years ago, and it's through technology that the defibrillators that I used in the early kind of 90s is now in the hands of lay members of the public in the form of public access defibrillators. And it's through the power of computing that has allowed that and has increased the survival for people in cardiac arrest across the world. And so I'm here today with my colleagues, David, you've met, David Rawlinson from EMERGE, Wales Air Ambulance, and Peter Richardson from Welsh Blood Service. And we're here to discuss today a project we've been working on. Yeah, you're going to click, do you? Yeah. Okay. So we're presenting a project which is exploring the use of drones in healthcare. This project came about following a study that we did with Snowdonia Aerospace. Okay, so the study I'm presenting today, or the project I'm presenting today, or we are presenting, is a foundation study for drone-based delivery services to support the NHS. It's a partnership between Snowdonia Aerospace, Slinktech, Welsh Blood Service, and the Welsh Ambulance Service. And here's some of the key collaborators. Just want to call out some key people. Alan Prosser, the Director of Welsh Blood Service, who had the vision to support us in this project, and Robin Davis. And for any of you who know Robin, if you make eye contact with Robin, you end up with a big project and quite significant change. And so this is part of a team that came together to explore the use of drones in the delivery of blood products across Wales. It came off the back of a project that we'd done previously with Snowdonia Aerospace, which was funded by the UK Space Agency, where we sought to deploy a defibrillator by a drone. The technology is pretty straightforward and is well developed in that area. But actually, lots of legislative and governance challenges prevent us doing that in the UK. And so that project was the start of our journey with drones, working with military experts, aerospace engineers, to unlock some of the potential of drones. And I'm going to show you a quick clip of what we believe to be the first deployment of a healthcare product in the UK beyond line of visual sight by drone, and it's a defibrillator. So this is a project that we did, and hopefully the video is going to play. Help, Anna. Is it going to play? You're going to do it, you, David. So this was a project that we used a fixed-wing drone. This was in 2019. Technology's moved on since then, and we flew this drone from Lambeth Airport, ex-military airbase, beyond line of visual sight to a simulated cardiac arrest. And in a parachute is a small defibrillator, a Schiller defibrillator, that actually hit the target, simulated cardiac arrest, within 50 meters. Doesn't actually look that much, but the potential for this in rural areas and for wider healthcare is quite is quite staggering, really. I was out in Antwerp only a few months ago, and we were in the European Resuscitation Council conference, and it's always nice to have your own research fed back to you. And a team in Portugal had picked up our paper, which we published in +1, and was really kind of hailing the success of our project. So, good example really of questions, challenges that come out of our practice in, for me, in ambulance stations like Builth and Llandrindod, has transformed into potential international solutions, working with technology developers. And so led us to where we are today. So project background with the Welsh Blood Service drone project. So after our initial project, we conceived a workshop with a range of partners, including, I'm glad to say, Rural Healthcare Wales, who have been supportive of our journey, not just in this project, but wider research and innovation over the years in the rural areas. And we explored the potential use cases of drones. A deployment of a defibrillator by a drone could be quite an expensive model if that's all they're doing is hanging around waiting for cardiac arrests to deploy these defibrillators. So the model we saw emerging was one which piggybacked on a wider infrastructure for delivering a range of healthcare products, samples, and healthcare services. And so we did our workshop, and out of this came a potential use case for Welsh Blood Service transportation of blood. So we partnered with Welsh Blood Service, Snowdonia Airspace, and a really exciting group of engineers down in the West Country called SlinkTech to develop a bid to Welsh Government to do this partnership project. And the project was in 3 phases. First of all, the background vision was for the Welsh Ambulance Service, Snowdonia Aerospace, to work collaboratively to invest in the potential use of drones. We facilitated this workshop and come up with the potential user case. And the vision was, and still is, for Welsh Blood Service to transport blood beyond line of visual sight from South Wales in Talbot Green, across the whole length of Wales up to North Wales. And Peter will give us a bit more of a context on some of the challenges the Welsh Blood Service face and the opportunities for drones. But these are challenges that don't just face us, they face many people across the UK. And in order for us to unlock the potential of the use of drones, we need the Civil Aviation Authority to have confidence in the safety and assurance of delivery of these products beyond line of visual sight. And so the project aims were, or the purpose of the study was to establish the context for a drone-based delivery service for the Welsh NHS, to test the basic premise with the Civil Aviation Authority, and then to identify a roadmap for critical tasks that allow us to achieve the longer-term vision. So the project was spread across 3 work packages. The first work package was led by Snowdonia Aerospace and involved all those technical and assurance cases that the Civil Aviation Authority needed. One really important document that the CAA need to be in receipt of is a concept of operations. And this maps out all the risks, all the potential opportunities, and a very technical document that the CAA scrutinises quite heavily to open up the airspace for the testing. The second work package was looking at the ground infrastructure, and this is led by SlinkTech. And SlinkTech has got we're limited in how much we could share in these presentations, as I'm sure you imagine, because we subject to non-disclosure agreements due to the innovative nature of the technology. But SlinkTech worked on and produced a model for the ground infrastructure. And then finally, work package 3, that was myself, David and Peter, looking at the use case in the Welsh NHS and managing the project and pulling it all together really into a feasible project for the NHS. So I'm going to hand over to David quickly just to give us his 2 pennies worth on.
Thanks, Nigel. So yeah, as I kind of mentioned earlier, work with the air ambulance. I think, well, what can the air ambulance need drones for? We fly our consultants, our practitioners to the scene of incidents. But if you think about the things we deliver blood transfusions at the scene of an incident. So this is more about the logistics of how that blood gets to us. So if you think of the blood we have in our helicopters, it's in a cool box, it stays there for 3 days and it comes out of hospital stock. If we don't use it, it goes back into hospital stock and is swapped. So that means we have up to 586 journeys per year between all 4 of our bases in Wales, back to the blood bank, back and forward. That's currently in healthcare services vans. When we started, it used to be in taxis. Very, very expensive to do. A lot of wasted kind of miles, and it's quite slow to do. We're recently using a bit of blood bikes as well, but either way, there's blood that needs to go between hospitals and our sites and back again every 3 days, and that's the way it works. So essentially, that's 2,000 units of blood a year. So we saw here an opportunity where these blood boxes could be transported by drone potentially. They'd achieve the journey probably a lot quicker between the sites, and we've got a real mixture of urban and rural journeys. So shortest journey is probably Cardiff Heliport to the University Hospital Wales and back. That's a relatively short hop, but the challenge there is it's a really built-up area, and there's challenges around flying in that airspace. The other one's Morriston Hospital to the base in Davin and Cynhadledd. Again, probably it's a 20-minute drive at high speed. If you've probably flown a drone, it might be 10 minutes. Mixture of urban and rural. The next kind of distance is YG Bangor to Carnarvon Airport. So back and forth there. Again, short journey, very rural, so should be fine. And then the longest journey we've got is Wrexham to Welshpool Airport. And again, every three days, that journey happens backwards and forwards. So that's our kind of use case, something we'd probably see a real advantage to that going forward. That's our routine work. The other bit is major incidents. So if there was mass casualty incident requiring a field hospital to be set up, fortunately it hasn't happened in recent years, but if that was the case, we would set up in conjunction with the merit teams in Wales, a field hospital, and we'd activate our major incident protocol, and the helicopter would fly to Llantrison, pick up 40 units of blood, 40 units of lyoplasm, and that would be flown to the field hospital or to the local hospital that we're sending patients to. So again, there's another use case there, and it's not scheduled, it's emergency work. So they're the kind of areas we would see this technology being translated into practice if it goes ahead and it's feasible.
Thanks, David. Okay, next slide. So, unfortunately, Jeremy from Snowdonia Aerospace couldn't be here today, so I'll cover this as best I can within my ability. So Snowdonia Aerospace looked at a number of options for electrical, vertical takeoff and landing. So these drones, unlike the one that I showed you earlier on, have got greater precision, and pickup of goods and equipment. So effectively, as the title suggests, they have a vertical takeoff and can land, so much more maneuverable. And this is, again, part of a bigger technical document that was produced in the CAA, which looked at the ground and air environment and all of the technical details that need assurance from the CAA. These are not skill sets that ambulance services have or wider health services have. So we need to work and co-produce this model with our experts, which happen to be based here in Wales in Llanbedr Airport. Excellent. It's not working. Can you move it on, Anna? So the project outcomes, initial requirements for the vertiport were noted. Again, this is written up into a much more technical document. One of the really important outcomes that we're quite proud of this project was a discussion that took place with the CAA Innovation Hub last March. And the concept of operations paper was presented to them, and it was facilitated through a detailed workshop. The CAA are keen to partner with us to use this as a safety case going forward and actually do live flights in the future. Talbot Green and the Wrexham sites were confirmed as 2 potential sites, and surveys were undertaken at those sites, very detailed, very technical surveys. And then a second workshop was arranged later on in the year to include the outputs of the findings of these site inspections and meetings with the CAA. So is this your Peter? Or is this your slide? No, we're still on Jeremy's. Yeah. So I hand over to Peter. Sorry, I didn't introduce you that well. Peter, so what are you doing?
Oh, that's okay. So, hello everybody, I'm Peter Richardson. I'm head of quality assurance at the Welsh Blood Service, but we're a small organisation, so everybody does a bit of everything. So research and innovation sits under me as well. So I don't know how much you know about the Welsh Blood Service. It's existed in its current form since 2016. Prior to that, we were the Welsh Blood Service apart from Cynhadledd, and prior to 1997, we were actually part of the UK Blood Transfusion Service. So as an all Wales body, we're relatively new. And we recognise that actually that makes us relatively South Wales centric because our headquarters and all our processing facilities are based in South Wales. We have stock holding and distribution facilities in North Wales, but effectively everything that is collected in North Wales comes south to processing. And then what's needed in North Wales goes back north for distribution. And a particular challenge for us is that some of our products have very, very short turnaround times and shelf lives. So we're effectively transporting north to south on a daily basis, which is probably not the best thing for our planet, and operationally gives us certain limitations. So for instance, you've probably all seen in the press that the UK is relatively short of blood at present. In Wales, we're brilliant. We're supplying the rest of the UK at present, but we lost 80 units of blood on Friday evening last week because of a van that was stuck in a traffic jam, and the blood got too warm in containers. So there've got to be better ways of transporting things around. But we could think of a number of different ways of harnessing drone technology. What we need to do was start somewhere. So we came up with two specific use cases, one that relates to the fact that we're still properly developing our infrastructure as an all Wales service, which is the emergency requests. But then actually a longer term ambition, we should be looking at more efficient and more sustainable ways of operating a north-south corridor for logistics. The emergency requests are a particular challenge for us. So if you imagine a patient in Bangor or a patient in Aberystwyth who needs an urgent cross match and specifically match blood back to them, we've got to get blood samples from those patients to Talbot Green to our specialist cross-matching laboratory. And then we've got to get the appropriately cross-matched blood from Talbot Green back to the patient. If that's done via the roads network in Wales, you can imagine the timescales that are involved. So actually a drone that can avoid the traffic jams, can operate 24/7, etc. There's some serious advantages there for speed of service and improved patient outcomes. We also have a challenge in North Wales because the time intervals can be so great sometimes that we have to send that cross-matching work across the border, so it goes to Liverpool or to Manchester. So the quality of the cross-matching, absolutely fine. That's a UK standard. The quality of the blood that's supplied from NHS England, absolutely no problem. But the record doesn't match because, of course, NHS Wales and NHS England don't necessarily talk the same language. So again, anything we can do to kind of keep that centralised record, centralised visibility, will contribute to better care for the patients. So that would be our priority to crack in this one. If we can speed up samples back to South Wales and the supplies out, absolutely ideal. Second would be the emergency request. Sorry, the routine transport. So at present, we send a vehicle once a day each way. What we have in mind actually is that, that brings limitations because if there are specialist requirements or sudden demands, so things like platelets, where we have very, very short shelf life, we tend not to keep a lot of stock in North Wales. But if there's an urgent need for a particular blood group of platelets, got to get it there quickly. So we end up either sending a specialist journey or the patient has to wait too long because it goes upon the normal daily transport. So a drone that could fly more frequently or on demand would certainly speed up that process and could significantly reduce our carbon footprint. So two starting use cases, by no means the whole story. This is, you know, this is just somewhere for us to kind of test the process, and you know, obviously we want to grow from there. I don't see a reason why ultimately we shouldn't be shipping everything away from the roads. And during the course of this project, we came across some really interesting work that's been done in Africa, where they're doing absolutely that. They're shipping blood across Rwanda using drones. So this is doable. But what we've got to do is now navigate the UK, because the regulatory framework, the airspace usage, and in actual fact, the safety profile of blood products is very, very different. So, you know, a bit of work to do, but we can absolutely see ourselves going here. Just click over onto the next slide. Although, oh no, did I lose my other one? No. No, it was, all I want to do was just call out that there was a couple of challenges that we do need to face into technically. So one of those would be, whoops, no. One of those would be that platelets, which are a fairly key product for us, they have very, very unique storage requirements. So if we're storing them for more than a day, we have to keep them agitated, but not too much, because we don't want them clumping together. And we also have to keep them at 20 degrees centigrade or higher, otherwise the platelets die. Whereas red cells, we have to keep them refrigerated at between 2 and 6 degrees centigrade. And there's not a lot of work that shows what would happen with red cells if they're subjected to regular shaking, i.e. being transported for long distances on a drone. So we've got work to do to make sure that we're not harming the blood products, and to make sure that we can maintain the right temperature profiles. But we don't think either of those are things that can't be solved. So massive potential here, and you know, we're really looking forward to taking this to the next stage. So, thank you very much.
Okay, thank you. Switch on to the next slide. There's a quick video. So the next slide, there we are. It's a video there. It's a video, yeah. So this is a model that was produced by Cynhadledd of Welsh Blood Service, and the potential. It's a virtual reality model that is of for training of operatives within Welsh Blood Service of what this service could look like. It's the vertiport system within the car park or within the setting of Welsh Blood Service. Actually fortunate that Welsh Blood Service are going through a change in their estates, and we're asking planners and people who are developing new hospitals to consider the use of drones and where they place a drone port, vertiport, when they're designing new hospitals. We work in Welsh Government, and again lobbying for them to include these in their plans for future buildings. And I say just a novel kind of piece of VR that Cynhadledd stitched together for us, which goes on a bit. Okay, I don't know if so. I think that was your slide there. Yeah. Okay. As Peter said, you know, we don't want to over-egg this. There's a journey to go through, and we're partway through that journey. We're working with the CAA, with industry leaders in drones. As Peter mentioned, a lot of these challenges have been met across the world, and we're learning from schemes such as those that have been conducted in Rwanda and other parts of the world. And again, we planning to do a live flight in the next year, but we're planning to do a high-profile sort of launch of a report off the back of this in the spring, where we do some live flights with a drone. So hopefully I'll share through Anna and Rural Healthcare Wales that we'll get some good representation to this event, which will be up in Lambeth Airport in the spring. So any questions? Well, thanks first of all, but any questions? Yeah. Okay. So what? Yeah, okay. So we had a colleague from Hywel Dda Health Board who's asking, was there representation on the flight path? Yeah. Okay, no activity, you know, in the Hywel Dda Health Board area. This was, I mean, mostly due to the fact that the user case that we're looking at with Welsh Blood Service, which came out to the workshop, was this flight from North to South Wales that goes on every evening. That's not to say that our plans absolutely are for a network across Wales. As I mentioned earlier on, just to use drones for emergency care, we don't think at this stage is feasible, would be cost effective or clinically effective, really. We see it piggybacking onto a model, a network with potentially 5 or 6 drone ports across Wales, delivering all sorts of products. And that's why we're asking for the health community in Wales to come to us with ideas, user cases, so that we can build this partnership and explore funding options to do the testing to make it a reality, really, in the coming years. So it's absolutely, we see Hywel Dda as a partner, as with the whole of Wales. We're an all Wales organisation, and certainly the partnership is slowly growing, but we are looking for other partners to join us, and part of that conversation hopefully will come out to the workshop that we have in the spring.
If I could add on to that, from a Welsh Blood perspective. So just to add on to that, from a Welsh Blood perspective, Hywel Dda is absolutely a challenging area for us. So, you know, the urgent cross matching would be, you know, it's an ideal place if you want to put your hand up to be the guinea pigs for us. We will welcome that. But yes, it's the west coast and the north coast of Wales are real challenges for us. So. Absolutely.
Thank you. And if the financial parameters, considering how much you're spending now, what you see as being the cost when you're dealing with the system, the entire plan is hopefully delivered.
Okay, yeah, so a question from Tom around the costs of this going forward. Well, again, we step it into the unknown, so we don't really know what the costs are going to look like. We know the technology is coming down in price because international partners are developing cheaper and cheaper drones and more efficient ways of doing it. But at this stage, these have all been just small amounts of funding, really, to get it off the ground, to work with our partners. We still don't know what a future model would look like in terms of the partnership. Is it something? It's certainly something which is a collaboration with industry, because as I mentioned, we don't have the skill set within the NHS. Would it be a service outside of the NHS, procured to the NHS? These are all questions, really, that we have, because we're certainly at the start of this project. So not the greatest of answers. Lots of unknowns.
I think we've run out of time. Sorry. Yeah, sorry, we're having to keep this schedule because we've got another plenary. But thank you very much to Nigel and the team. Have we given track? I was just thinking that maybe there is some potential for collaborating with Charles on his Think projects in terms of transport, especially if there's funding there. Yeah, so thank you. And we're having really good value from David today, because he's coming back now to do the next breakout. If anybody wants to change room, either virtually or in person, now is your chance. We've got a 3 to 5 minute changeover. This room, we're going to again be looking at an analysis of neonatal and obstetric workload performed by a national pre-hospital critical care service.
Yeah, my microphone is on. Okay. I'll put that up a bit, shall I? I'm not sure about the camera angle here, but hopefully it'll be all right for people at home. So hopefully the last presentation for me today. I've covered a bit of telemedicine, a bit of drone stuff. Now I'm coming back to what I was generally here for, which is the air ambulance side of things. I was due to be presenting this with Peter Collett today, who's an anaesthetic trainee, but rather aptly his wife is having a cesarean section today, so is unable to join us. So I'll do my best to cover it. So in terms of the EMRTS and the air ambulance, we've got a number of kind of benefits across Wales. One is improvement of equity of care, of access to care. In terms of the rural healthcare, that means you should get the same level of service as you get in an urban area, whether that's major trauma or cardiac care, cardiac arrest, or indeed neonatal care in the case of the theme today. We also look to improve patient outcomes. So not just improving mortality, but getting people back to work, back to normal life. And also because of the regionalisation of specialist services, we find people become de-skilled in certain areas, that particularly in major trauma, also in care cardiac arrest, but also specifically neonatal care. And we also try and bring downstream benefits to other parts of the health service. So whether that's doing a transfer of a patient between hospitals, so we leave the hospital staff in their own hospital so they can carry on with work, or whether we go straight through and bypass the emergency department and go straight through to a CT scanner or the surgery. The EMRTS kind of context is that it went live in 2015 from Swansea and Welshpool, and we expanded into Carnarvon in 2017. And then since then, we've undergone a huge number of service changes, including operating 24 hours a day. And we're about to undergo some further expansion in Mid and North Wales in due course. Who are we? Well, it's a group of medical staff. So the full-time employees are what we call critical care practitioners. They're nurses and paramedics with advanced training, and they're able to deliver a full suite of hospital level critical care. But at the scene of an incident or during a transfer. We also have consultants, fellows and FEM trainees, i.e. from a medical or a doctor background, and they're all within the specialities of emergency medicine, intensive care and anaesthetics. Now in the context of the neonatal workload, this is really important because the majority of people in those specialities predominantly focus on the care of adult patients because of the regionalisation of paediatric care. This presents particular challenges when you then tasked to looking after a neonatal patient or indeed some of the paediatric cases. Luckily, we do have a number of consultants and CCPs within our ranks that do have a special interest in paediatrics. We've got emergency medicine paediatric consultant, we've got a paediatric anaesthetist, and we've actually got recently addition of a advanced practitioner in neonates who's just joined us. So for them, they're used to dealing with children perhaps more than adults, so they find a different challenge in their day-to-day work. Whereas the rest of the bulk of our staff, they're used to looking after adults. Luckily, because of the way it works in Wales, you still do get regular involvement with children and babies through your work, and especially as an anaesthetist, we interact with neonates and the mothers on the labour ward. So a lot of us have experience from that perspective as well. We operate from 4 sites across Wales from the emergency service, and we also have another site in the YG hospital in Bangor for our road transfer service. But predominantly for this presentation, we're talking about Carnarvon Airport, Mid Wales Airport, and Welshpool, Davern and Llanelli, and Cardiff Heliport. They're all coordinated by our staff in the Welsh Ambulance Control Room in Cwmbran, and that operates 24 hours a day. The service is a unique collaborative partnership. We've already heard about how we're working with Welsh Blood Service to deliver blood products. We work with the ambulance service very closely because they receive the 999 calls, and actually the majority of patients we go to will already have an ambulance response before we get there. And if they don't have that before we get there, we often use their ambulances to get to hospital. We tend to use our aircraft as a response vehicle rather than transport method. We're hosted by Swansea Bay University Health Board nationally, and we partner with the Air Ambulance Charity. So just to give you the context of what we do, last financial year, just over 3,200 incidents, 54% we attended by air, 46% by road. We conveyed 68% of patients to hospital, and that was a mixture of road and the ambulance service, and also in the aircraft. We averaged 9 calls per day, and we delivered 119 blood product transfusions, 141 procedural sedations, 412 anaesthetics. And in terms of the number of incidents we review, so we only go to 3,300. There's about 500,000 999 calls that come through. So we have to do a lot of filtering and work out which cases we benefit. So there's about 51,000 incidents that we've reviewed in great detail to get to those 3,200 cases. We attend cases across the whole of Wales, and the bulk of our work is trauma, just over 50%. And in terms of the subjects I'm about to go into, the maternity and neonatal cases, they make up 1% and actually less than 1% consistently year on year. So that provides a real challenge for us. More recently, we've had the introduction of the adult critical care transfer service, which is 2 road-based resources. One is 24 hours in North Wales in Bangor, and covers all the North Wales hospitals, and then one 12-hour day service in Cardiff, which covers the South Wales hospitals. And we've done over 500 transfers in the past year. They're all adult transfers, and that's largely adult workforce. But of interest, there are some, I'd say, mad people, but there's some consultants that decide to do a bit of paediatrics and adult work, and maybe have 2 or 3 subspecialities. They must like exams, they must like their work, but there are some paediatric specialists within the ranks of the adult critical care transfer service. So there's potential scope there for things. But going back to the kind of main EMA service, what we deliver is pre-hospital critical care. So it's largely trauma, as I said, and post-cardiac arrest patients. But we also do a proportion of retrieval work, mainly for adults, and that's usually time critical. So good example would be spontaneous bleed on the brain and you're in Glangwili and you need to go to Cardiff for neurosurgery, or a major trauma on Anglesey and you need to go to Stoke for your neurosurgical care and your trauma care. So the bulk of our retrieval work is moving adults around. The reason we don't specifically try and target children is there are specialist services. There are in North Wales, there's Newts. In South Wales, there's Chance are 24 hours a day now, and they're for the neonatal team. There's Watch, who do paediatrics and a little bit of neonates as well. It's always an interesting thing around the neonatal definition, because if they haven't left hospital, they're a neonate. But if they go away and come back, they seem to come into the paediatric team service. So you may get 2 or 3 different services competing or arguing over the patient. At the end of the day, if no one's going to do it, we'll do it. But we try and avoid it because it's not our specialist area, but we do train for it. And I'll go through some of the stuff we do with that. But our preference is to engage the other services because they are the specialists. And sometimes that means just giving them a helicopter to get them somewhere quickly. So we did a project looking at all the neonatal and obstetric workload that we've performed since 2015. We tried to do this when we started, but we've realised this volume is so low, it's really hard to analyse in any meaningful detail. We had a set of KPIs, performance indicators. It's pointless doing it on a small number of patients. So this is more of a qualitative review in essence. And I think we still need a bit more time to develop the kind of power of numbers that we need to do to draw any real conclusions, but nonetheless, it's quite an interesting description of the work that we've done. We did our first neonatal mission in 2015, shortly after launch, and then we did our first formal incubator transfer using a specialised incubator from Switzerland, and that was in 2016, and it was between Glencoe Hospital and back home to Carmarthenshire, and we did that with the Chance team. So those kind of transfers where we're just doing elective stuff with the Chance team or the Newts team save huge amount of time. Wasn't this case, but there's another case where we repatriated twins, so the mother had been away in North Wales on holiday. That would have been 2 8-hour round trips for the team to do, and we managed to do it all in one day and got both twins and the mother back home to South Wales, which frees up neonatal cots essentially in the hospital, which are already a scarce resource, and it means the team can also then respond to other incidents. So there's a bit of joint working where we provide a helicopter, and there's some where we actually go to the incidents ourselves. So these are the kind of headline things we do. When we were set up, we did the business case in 2014, and we anticipated there'd be a number of changes to midwifery-led units and consultant-led units in Wales. We were expecting closure of some of the West Wales ones. We were expecting closure of some of the North Wales units, and change to midwifery-led units. That didn't happen. There was a lot of public outcry. There was a campaign, and those units remained open. So originally we were in part going to be a safety net for those changes, but luckily for everyone, we didn't need to fully enact that. So that's perhaps why we haven't seen the level of activity. But we have a whole suite of governance and access to advice from the specialists. So we actually reached back to the consultants and the retrieval teams, and they've been involved heavily in the design of our training and our procedures on that. Essentially, if you're in a midwifery-led unit and you've got a problem with a neonate or the mother, you'll get a 999 ambulance response. They will go to the incident and they will provide support and transfer. That's where we come in. We can get involved in that if it's required. So we can support the ambulance service. We don't replace it. We don't transport mothers around the pregnancy period in a helicopter. That's a big no-no. There's lots of reasons you don't do it. It's very hard to treat someone in a helicopter, and you definitely don't want a baby coming out in a helicopter or a mother bleeding, etc. So going back to the range getting heavier, isn't it? Going back to the kind of the preference for using the retrieval team specialists, we actually do a period of training with them. So we ask them to train us in neonatal resuscitation and skills, but also if we're going to let them use the helicopter, there's certain things they need to know about that, and it's completely different. You know, essentially this room is like being in a helicopter. You've got headphones on, you lose parts of your senses, and at the same time you've got to look after, you know, a 30-week-old baby. You can't hear the alarms, the monitor might be vibrating, the baby, any small movements can impact the airway and things. So we pre-prepare for that and get all the nurses from the teams and the consultants from the teams down to our base, sit them in a helicopter, fly them, show them how to use the incubator, show them how to use our equipment. We support them on real transfers, but it allows them to experience some of the restrictions before they have to do it in real life. In terms of the skills they give us, we do advanced training, so we do the neonatal life support courses. All our practitioners and consultants would be happy intubating a baby or putting airway devices in. Our practitioners know how to operate the incubators, which can either cool or warm a baby. We give antibiotics to neonates if indicated. We have the umbilical venous catheters were also one of the skills, which is very rarely used. So it's been in and out of service for the past 7 years. We've gone through periods where we've stopped doing it because there's no need for it. And also it's a skill you need to practice to retain. But it's back in service now. And then CPAP, which is the kind of respiratory support with a mask, which avoids the need for putting a tube into the windpipe. In terms of the review we did, it was over 7 years, average of 17 cases per year, 120 cases now. Our number of staff is about 220. So if you think about it, most staff won't have ever seen a neonate. Funnily enough, within the data set, some people tend to attract these cases. It's a really odd thing, but there will be 3 or 4 people that will have seen the majority of these cases. It's either because they're all focused in a certain area, or they're just very unlucky or very lucky. So some people are really good at it, but some people have never seen a neonate in this environment, which is a huge challenge for the training and competence side of it. But we've essentially done 68 secondary transfers, so 44 with the retrieval teams. So we just give them a helicopter and we support them in that transfer. And then 24 are ones we've done because there's no retrieval team available and we are the only option essentially. We've then done 52 primary missions. So these are the 999 calls. 42 have been relating to home births and 10 at midwifery-led units. If units have been downgraded from consultant-led units, we'd have probably seen higher numbers. Because it stands, there hasn't been much change to the actual provision. And within those emergency calls, 33 were related to the birth itself, rather than just the neonate. In terms of where we've been, there's a heat map there. Most of our heat maps look the same because the bulk of the population is in South East Wales, so you see increase in activity. But really interesting, you do see a spread of activity up into Mid and North Wales, both hospital transfers and home births where we're providing support. And there's nothing in the kind of far reaches of Haldar, which is probably good. It's probably because they've got quite good, they've not experienced the same incidents, or there's a good provision of care, and that's one of the areas they were looking at downgrading the unit, which they didn't do. So just to give you an idea of what cases we do. So this would be a case where we've supported a retrieval team. So we've gone to a 1-day-old baby that's really sick and brought it back in. So they've gone home and been brought back in. They've got really low oxygen saturations, essentially a blue baby, floppy. They're trying to resuscitate them in the hospital in Withybush. Essentially, they need to get to a neonatal unit, or they need to get to kind of specialist care. So our initial response was to send a team straight to it. It's a 999 call. It's an emergency. They assessed the airway, they prepared the ventilator, prepared drugs. We quickly call in chance and watch, and this is where you get to this challenge of which team it is, because the baby's gone out of hospital and come back in, so technically they fall under the watch team instead of the chance team. They're not the kind of arguments people want to be having when you just need someone, and either team would be better than our team. But either way, we've managed to coordinate that and have conference calls. We take advice from them, they tell us what to do. This baby was particularly difficult to ventilate. They were unable to secure an airway, so it's looking pretty bad. And it's really high stakes, this. So they gave a variety of drugs, both to kind of sedate the baby, resuscitate them, but also deal with the condition they had, which was transmission in the great arteries, which needed surgical correction. Whilst the drugs could temporarise it, you need to get to the consultants. And this is a case, probably we're doing use telemedicine as an option. But either way, this patient needed to be moved quickly as specialists to Bristol for surgery. So in that case, we used the helicopter to get the team, the specialists, to the child, and then effected a transfer to Bristol, and the baby had surgery and recovered well from that. So that was quite a complex case, but shows the importance of the clinical team, the coordination, and the helicopter. This was a community case, 999 call in Treorchy, home birth, premature, unexpected. We flew straight to it as an emergency. WASP went to it from the ambulance service perspective. We delivered neonatal life support. And one of the main differences here is whereas if WASP were there on their own, they would have probably taken them to the local hospital and then had to wait for a transfer from the chance team. Because we had a consultant team trained, and with the equipment we have and the baby pod, which is like a smaller version of an incubator, we're able to bypass other hospitals and get straight to the neonatal unit. And that baby arrived in good condition and had a really good outcome. And I think the outcome's the nicest thing here. If it goes wrong, then it's really bad, it's really high stakes, but a lot of them have really good outcomes, which is really pleasing. So in terms of all of those cases, we've gone to the 120, 31% cardiac arrest. So the blue baby usually not breathing. It's actually quite hard to tell if a baby's in cardiac arrest or not. It's hard enough in an adult to teach someone to take a pulse. In a baby, it's very difficult. So these are essentially the blue floppy babies that aren't breathing. And the phone, when you phone 999, will be saying start chest compressions. So 31% cardiac arrest. Respiratory failure, these are again blue babies, but with a pulse, 37%. 12% no abnormality. With babies, especially when they're just born in the neonatal period, it can be very terrifying, especially new parents, but also sometimes babies do look pretty unwell when they come out, and it's just part of the natural process. So often 999 is called it quite early, and actually those children, by the time you get there, they kind of recover, which is the best outcome you can have. You just turn up and they go pink and it's all fine. Within the other category, it makes it 20%. These are all kind of ones and twos numbers of cases, but we've got cardiac abnormalities, gastrointestinal stuff, trauma, sadly. I think there's a road accident, postpartum hemorrhage, premature labour, some neurological issues, and then sepsis is one of those other calls that we have. In terms of the 120 cases, 33% required some kind of critical care intervention outside of the standard ambulance practice. And that's something that if we weren't there, the baby would have required transfer to hospital to then receive those treatments, and may not have even got them in their local district general hospital because we don't always have a paediatric team there available. One of the other things we kind of looked at is the complication rate. So we only recorded 4 complications in this case series, so 3%. Technically, it's difficult. We're still debating this because we're writing this up for publication, but we thought it'd be good to bring it here today. The futility was recorded as a complication, but actually there's nothing you can do about that. So it may actually be excluded. We had a couple where we had to change the tube in the trachea. Again, that's sometimes seen as part of routine practice. Tubes don't always, you put one size in that's predicted, and then there's a bit of a leak, you put another one in. But they were recorded as complications. And then a case where they're unable to intubate. And I think in that case, the hospital were unable to intubate as well. But we were treated using the mask essentially. Looking at literature, complication rates for transfer range from 20 to 30%. It's really hard to draw conclusions from such a small sample. And so that, again, we just need a bit of a bigger sample over a longer period of time. But we're pretty happy that we're delivering the right care there. So in terms of conclusions, well, we think we've made a valuable enhancement to care as part of our service. It's a tiny piece of the work we do, but it's in line with the founding principles of our services: care for anyone that needs it, and it's providing equity. We think we've got a low complication rate, but we've got nothing to compare it to because we're pretty much the only service in the UK that delivers this kind of enhancement. It's unique to Wales. The biggest challenge is maintaining competency because our workforce are largely adult doctors, adult CCPs. How do you maintain that beyond doing a course every year? If you don't see the patients, then it's difficult. But equally, the ambulance service don't see those patients. So it's how you focus that and how you deal with it. But we find having standard operating procedures and training is key. So practicing it, running through it. And we do a lot with cognitive aids, so flashcards, like we do in aviation. So a list of things you need to do. But again, going back to the basics of it, we prefer the specialists to do it because they do it every day. You probably wouldn't want those teams transferring adults. I'm sure they'd be fine doing it, but children aren't just small adults and vice versa. So we always try as a default to facilitate the commission team to do it, and then we're the backup. And just finished with a nice picture of North Wales and one of our ambulances and helicopters, because that's one thing to make a point of is the helicopter itself often isn't the ideal thing to transfer a baby. There's hardly any hospitals in Wales where you can land at the front door. You have to get in an ambulance between it. So actually you might have, flying from A to B, but you have to get in 3 ambulances in between it. And there's lots of backwards and forwards. So the whole journey is quite long. So helicopters, although they can fly 150 miles an hour in a straight line, sometimes it's quicker just to get in an ambulance and go. And that's sometimes what we advise. And that's all part of the kind of coordination of it. So yeah, thank you. It's just a summary of where we are to date. And we're hoping to finish off that piece of work and publish it in due course. Yes, it's hard competing with that. Thank you.
Ready? Hi, one and all. We have our last plenary presenters online from across the water. So in order for nothing else to go wrong in my digital world, if you don't mind taking your seats, we'll kick off the last plenary presentation. So if you could grab a seat quickly. So our last plenary presentation comes from Canada and from Ceredigion. Are they both on? Yeah. So there's been a link between Ceredigion and Canada to study the way to deliver services in rural parts of the world. So I'm hoping that Sharon and Helen are on from Canada, and I shall pass over to them. Thank you very much.
Good morning, everyone. I'll just share my screen here with you. My name is Sharon Hamlin, and speaking with you from Alberta, Canada, where this morning it is a frosty winter morning at minus 22 Celsius, which is about -8 Fahrenheit. So we're cuddled up with our coffee here this morning. Together with my colleague, Helen Lightfoot, we're so thrilled to be here today. Thank you for the opportunity. We were able to attend last year and have made some connections that we continue to meet with and learn some from. So we're excited to be here today. So over the course of the next 20 minutes or so, we'll provide a bit of an overview about our work to date and with 5 rural communities in Alberta, Canada. So before doing that, we'll just provide a really high-level overview and set the context for things here. So this is a map of Canada, which has a population of right around 38 million people. It has a publicly funded healthcare system. Alberta, as you see noted there, has a population of around 4.5 million people and has one single health authority, Alberta Health Services, who Helen and I work for, which is the largest single health authority in Canada and employs around 102,000 people. Alberta is one of 3 prairie provinces in Canada and has a diverse topography. It has 2 major centers of around 1.5 million people, and then a number of smaller kind of mid-size urban centers between 60 and 100,000 people, and the remaining in rural settings. Our work is more focused in those rural communities. And the reason being that often, as you would know, similar to your work there, the rural settings often have less resources. And we often see then the population or the demographics in those rural communities being such that there's a greater percentage of those over 65 who are aging in their own homes and communities in rural settings. So in Alberta, we have about 90% of people 65 and over who live in their own homes. Just for context, from a facility living perspective, there's about 3% that live in a continuing care or long-term care facility, with the remaining percentage there in some facilities that do offer some supports, but aren't that full facility care. So in 2020, the National Institute on Aging in Canada posed a survey which looked at a number of things, but one of the things they were interested in was, where do people want to live as they grow older? And almost 100% of people wanted to continue to live in their own home, which I expect isn't a lot different than what you would see in your own country. What we feel this is a real sign for, though, is a bit of a call to action in terms of how do we support people to live in their own home. Our current system perhaps isn't set up to do that in such a way to support people to continue to live there. And so our work in rural communities is really trying to focus in then on how do we keep those people in community. So now we shift a bit more into our own work. Our work is grounded in well-being. And what is well-being? Well-being is the ability to be and do as one values. And it encompasses the number of elements and domains that really honor us being able to continue to live a good life. And in a few minutes, Helen will speak of some of the learnings that we had with respect to our applied research around well-being for the populations that we were looking at. So with our minds a little bit on well-being, just wanting to ask you to all reflect on your own well-being and what contributes to that. There are a few pictures on the slide here which may resonate with you: family, community, travel, exercise, and just ask that you keep those in mind as we continue to go through our deck and understand kind of how this work relates to all of us then on that kind of human level. So you'll recall the statistics of around 100% wanting to continue to live in their own homes. And we feel that a focus on well-being can really help to create a foundation on how that support can happen. So the model that we refer to in our work is the McGregor model of well-being. And in that model, there are three components to well-being. One being the material, which is what one has, which includes things like food, transportation, housing. The second being relational well-being, which is what one can do through their relationships with others. And that includes both personal relationships and those within their extended community. And the third component is subjective well-being, so how one feels and evaluates about what they can and have do. The overlap between these areas, we feel really provides a nice frame to understand how care or models of care really need to honor that overlapping of what our human needs are, and then a model of care for the future state that can support us to continue to live well. This graphic here is adapted from the Aging Well report, which was put out by Queen's University in Canada in November of 2020. Excuse me. And it really demonstrates the transformation that's needed in our own system. So we've got some animation here to bring things together, but as the graphic changes, you start to see how the components of well-being, that material, relational, and subjective, really line up with what is suggested to be a reformed model of care. So one where rather than addressing each one of these four components individually, there's an overlap and an understanding that as human beings, we live in this crossover where social, housing, lifestyle, and care all impact our well-being and how we're supported through that lifespan. So how will transformation happen? We are a big fan of work done by Cormac Russell and the Nurture Development Organization, and felt that this quote really sets a nice segue into our own model of care, which we'll talk about here in a minute, and as well represents what one of our core principles is, which is really reflecting how do we create more space for community to do what they value at that local level. And so this is our model that has been developed over the course of the past few years in this Health Canada funded grant portion of our work. The model has 5 components, and at its core, you'll see there the goal of supporting individual and collective well-being at that local level. On the left is that provincial support, which represents the work that both Helen and I, and we have a colleague, Shauna, on the line today as well, do to support the teams at that local level. And really, our role is supporting them to implement that model locally, but also building that evidence and being an advocate for them. So sometimes at our provincial level, we have the ability then to access levers which can't be accessed by that local community level. And so how do we leverage those resources to support this work to happen? The second component is the local communities that are advancing their work. The multi-sector teams that we work with refer to themselves as community collaboratives or community coalitions. And there's diverse representation from across sectors, which include the health sector, social sector, community and volunteers, and as well representation from those with lived experience. They have a deep awareness of their local resources and what the local needs are. They're just so connected locally. And of course, at the foundation, they come together with that common purpose of supporting people in their community to be able to continue to live in their own homes and community. The 10 core principles at the top middle there are listed. And, you know, the model in itself can be applied both at that provincial level. So we look at this and consider these components daily in our own work, but they also translate at that local level to things that can be done there. Well-being, which is on your right, the well-being guide, which was one of the key deliverables of this current grant and really was built through learnings from applied research, which Helen will speak of, as well as targeted literature search around well-being. And it really is a way to measure and monitor the impact of the actions that these community teams are taking. And how is that impacting both those living in their community, but also then how is that supporting them as a collaborative to be a sustainable component of their local care options? And over time, information captured in the well-being guide will also start to tease out what kinds of things aren't able to be achieved at that local level. As such, it starts to shed some light on what are some of those policy or infrastructure changes that might be needed in order to support communities to continue to do this work. And the competency framework is that last component. And it's really a way that articulates the skills and knowledge needed to support people to live well in their community. One of the largest myths that we continue to have to bust in this work is that this kind of work, working together, working collaboratively, happens naturally. And what we just learn and see demonstrated over and over again is that there are intentional efforts that need to be made. There are particular skill sets and knowledge that need to be known for this type of work to be successful. It's more than a matter of getting people together in the same room and trying to address a problem, that there are some key ingredients that need to be in place. What we've also heard around that competency framework from members of the collaboratives is it gives them something to take back to their respective leaders as evidence of the work and what skills are needed to support them in continuing their education around that and advancing their learning needs. So I'll hand it over to my colleague Helen, who will continue on with the presentation.
Great. Thanks, Sharon. Yeah, so we wanted to start with really looking at what we learned from that applied research, I guess almost 2.5 years ago. What we did is we did interviews with people living with dementia, carers, and then focus groups with the members of the collaborative teams. And then theme that information as well as taking the information from our targeted literature search. And 4 really strong themes came through for all 3 of those groups. And I think probably people can relate to this once we are going through them. So everybody wants the opportunity to contribute to their community, whether you're a person living with dementia or a carer or a member of that collaborative team. Meaningful relationships are how the work gets done. It's how people are able to accomplish what they want in their lives. Everybody talked about a safe space to be able to share their feelings, emotions, but also share learnings that they've had. And then also wanting to be active in planning and implementing supports. So having a say in the supports that exist. So what we'll do now is go more directly into each of these groups and what we found there. We termed it well-being contributors, the themes that came out of those interviews. And so each of these things, there's 10 to 11 for each of the groups, excuse me, that were identified as contributing to their well-being. That's what they said. So for people living with dementia, it was that housing, food, and clothing needs were looked after. They also talked about their care partner or family help so that they were able to do the things that they wanted to do. They saw a need for community education about living well with dementia. They wanted to be involved in their community. They also recognized that relationships helped them maintain their sense of purpose and meaning. They wanted to be able to have their confidence in their ability to adapt to what they knew were going to be changes related to their dementia, as well as a big one that came through was that whole person support. People often found that once they had a dementia diagnosis, everything else got removed from them as a person. So they still have physical, emotional, spiritual, and cognitive aspects to their personality. They talked about built-in natural environments and fostering inclusion and a sense of safety. And they also recognized the role of technology in helping them to connect with people. Now we'll look at the ones for carers. So again, the housing, food, care, and clothing needs, those basic needs there. Again, education was important to them, for themselves, and also for the community. They also wanted choice in how supports and services are delivered and what were available. Saw the key role of supportive relationships and especially positive relationships with healthcare. So they felt that they were part of that team and not having to struggle to find where they fit into there. Technology and supporting connections again, and a big area, emotional and psychological needs. This came out over and over again in the interviews. Related to that was their ability to maintain their own sense of purpose and meaning as an individual, and that carers really saw and recognized their own abilities and wanted that recognized also. And again, that need for a safe space to be able to share their emotions, the frustrations, but also to share the learnings that they had had. And then our final group around the collective well-being for the community teams. The well-being contributors that came out there were around having enough time and resources to be able to do the work, having a shared vision and purpose. They really felt that when their group coalesced around that, they saw a lot of action and things put into place, which leads to that outcome-focused work. Everybody talked about, we want to see a change. We want to make a change in their community. They saw that teamwork and relationships are foundational to the work that they are doing. They also saw that their work and that community level work needed to be a policy priority and that there seemed to be an absence of that right now. Communication was a key skill for everybody to have. They also saw the need for diverse membership so that they had different perspectives and that they had a need for ongoing learning in different areas. And then key to everything was that input from people living with dementia and carers. So these research findings inform both the well-being guide and our competency framework. And I'll go to the next slide there, Sharon. And so for our well-being guide, there are 3 sections within it, and this is used by the multi-sector teams to help them set priorities and determine activities that they wanted to carry forward. Within each section, there's a section for people living with dementia, a section for carers, and then a section for community collaboratives. And the sample we have here is from the community collaborative one. Each contributor is listed there. You can see the sample is time and dedicated resources, an explanation, and then questions that kind of inform what information would be useful within there. And so then their discussion is recorded within the resources and gaps. It's a fillable PDF, this form is. So after some discussion and kind of exploring all their options there, what they do is they set a priority, and you can see that down under cycle 1, chosen activity. To the left, there's that pre-implementation rating. And so they might say, you know, we need to do a lot of work in this area, so that'll be a red, a number 1 priority. Or we've done some work, we need to do some more, that's a number 2. Or actually, you know what, we've done a lot of work in this area, we're pretty happy with where it's at. So when they've chosen an activity, they record that there. And after some time of trying to implement that activity, they will come back and do a post-implementation rating to see if they feel that they have impacted that well-being contributor. One of our new aspects of this form is that we're able to pull a summary report from it that shows the teams, all of the contributors, the ratings that they've done on that, and the activities that they have been trying to pursue with it. It also is very helpful to us to be able to look at what are the areas that have been scored as red, as high priority. They've put a lot of effort into it, and maybe that hasn't moved as much. So maybe those are the areas that prior policy needs to be targeted at to make this possible. And in terms of the persons living with dementia and carers sections of it, the questions are all posed in terms of what the collaboratives can know about it. So as an example, in food, housing, clothing, it's what resources do the collaborative know about within their community that can address those needs, and are there gaps in there? So they're using their knowledge of their community to answer those questions with it. So we'll have a look now at the competency framework. So this information from the interviews and the focus groups was also applied to the competency framework. We were able to contract with a company called Psychometrics, and they looked at the themes with that had been found within the research, but also looked at community reports that we were able to provide, and some feedback from groups that regular meetings that we'd had with the community teams. And so out of that, 10 competencies were developed that really, if the teams are able to pursue these and learn about these, it will really support their success in this work. So underneath, there's 3 groupings of them. So there's the working with others, which looked at collaboration and teamwork, building partnerships and networking, interpersonal skills, and then communication. An area called service to others, and so that looking at the whole person approach, being community focused, and then those action oriented and outcome focused. And the third area of ideas and problem solving, so that continuous learning and sharing knowledge, creativity and innovation, flexibility and adaptability. In the next 3 slides, we're not going to go into it in depth, but this information is there for you to have a look at that gives really details about each of those areas. So Sharon, I'll get you to just flip through those ones. Okay, and so we just wanted to share a little bit about what we have seen the communities build so far in our work with them over the last couple of years. So things like falls programming, singing programming, Compass program training, which is care support group training, intergenerational activities, memory cafes for people living with dementia. So a wide variety of programs that really have met the need within those communities with it. Then I think one more, to the next slide, Sharon. So what's next for our team? We are a grant-funded team. We are in discussions with Health Canada for further funding, and what we have proposed is to look at being able to spread this model to new communities, to then also look at scaling it to possibly new populations. So looking at within rural communities, what other groups are underserved and how can this model be used to meet their needs, to sustain the communities that have already been involved, and then to start to develop policy and infrastructure recommendations to go forward, as well as looking at evaluation and possibly different ways of doing evaluation. We've recently done a update on our return on investment evaluation, but we are also pursuing a social return on investment. So what is the social value of the approach that is being taken? So I think now we are handing that over to Sarah and Jen, and we'll take questions at the very end. Thank you.
Thank you, Sharon. Thank you, Helen. We have been working with Alberta Health Services quite closely over the last couple of years, but we've never actually met yet in person. No. So hopefully that can happen soon. So we've heard a lot today about post-registration services, what's happening at certain universities and so on, but we're taking a little bit of a step back. So at Coleg Ceredigion, just to put a little bit of context to our presentation, we offer post-16 courses in health and social care and health sciences. So this is a an alternative to A-levels, for example. And the couple of courses that we offer in health sciences are the level 3 health and social care with applied medical sciences. And this is equivalent to 3 A-levels. So the majority of our learners go on to study at university with paramedics, nursing, midwifery, allied health, and so on. And the other course that we have
is the Access to Higher Education Diploma in Health Sciences, to which I'm the course leader for that. And that's for mature learners, those who are usually in their mid-20s or the up to the 60s if they wanted to be. And for them to come on to that course, it's a 1-year course as opposed to Sarah's course, which is a 2-year course, leading on to similar careers such as nursing, paramedic science, occupational health, physiotherapy, midwifery, as well as social sciences, psychology, criminal psychology, and teaching.
So background to the project that we started nearly 2 years ago now, which seems a long time ago, is that we recognise that a lot of our post-16 learners, especially after COVID, after the pandemic, didn't actually understand the basic challenges that affect health and social care. Certainly in Wales as a whole, but definitely in rural areas. So we put a bid in for funding through a UK government touring scheme. And it enabled us to take 10 learners out to Alberta to meet with Alberta Health Services to see that actually the challenges that we're seeing here, to demonstrate to their learners that it's a worldwide problem that we're seeing.
So some of the partners that we developed over the last couple of years, our main partners really are Alberta Health Services and Northwest College. It was quite wonderful really when we went out there. They rolled out the red carpet for us. We had heads of department from every department you could possibly think of in Alberta Health Services. We had Sean Chilton, which is the VP for People, Health Professions and IT. He spent a considerable amount of time with our students, including the Associate Chief Nursing Officer as well. Like I said, lots and lots of heads of departments. Rural health and social care, obviously, we're here today. Anna Bradach has been fantastic in supporting our project and our academy, as well as providing us with a representative to interview our potential academy members. So they've been vital in our project. Northwest College is a new partner, but is fast becoming a very large partnership for the academy. They're providing us with all sorts of academic activities once we're out there, seminars, workshops, social activities with students to provide them an idea of what college life is like in Canada. Aberystwyth University is a partnership for us, especially the nursing department, the health and social care department. And Cynhadledd Jones has also been quite involved in our academy in terms of interviewing possible academy members as well. Once we were out in Alberta, Rural Mental Health Project was providing us lots of different types of workshops. We had FCSS, which is our Family and Community Support Services out there. And we spent, I think, about a morning with them, didn't we? And providing a workshop and a tour of all their services. We spent some time at Origin Spring Creek Residential Care Services to provide our students an idea of what residential care is like out in Alberta, which was quite an eye-opener. It really was. And of course, we can't forget Sharon and Helen, who you have just heard from. They have been incredible support to us in providing a structure for the academy and what we need to go and see once we're out there. They have been wonderful.
So findings from this project, when we visited Alberta back in March of this year, there were a variety of similarities and differences that our students observed. We've just got a few here that we just want to go through quickly today. Nurse and allied health professional education. I know we're struggling in this country with recruitment of nursing staff, for example, but there are different categories of nursing qualifications out in Alberta. You have healthcare aides, that have to go through a college course. You have licensed practical nurses, you have registered nurses, registered psychiatric nurses. So for our students to be able to see the differences with what they're going to be doing in the future and maybe be involved in some changes possibly. Something else that we saw was regulatory bodies. So all of these different professions within nursing, within the allied health professions, all had different regulatory bodies. So with nursing, for example, you had three different regulatory bodies instead of this country. You know, in this country we have the NMC that covers all nursing and midwifery.
We also spent some time looking at Indigenous wellness, where our students spent an afternoon with a member of the Métis tribe. And she showed us all about various different natural remedies that can be found in the natural environment. And it was really quite amazing to see how involved the students were in that particular activity. But findings from that in particular showed that there are quite a lot of, considering a lot of cultural identities and historical perspectives and experiences to improve our future service delivery and communication. And there was also some parallels that could be considered, well, drawn between our cultures, and follows on from the More Than Just Words strategic framework initiatives as well.
Social housing models, quite an eye-opener out there. They do have some restrictions in social housing, as we have in this country, but there are also some very good models out there. We visited Cochrane social housing model, a town about 20 minutes northwest of Calgary, where they have family services on the ground floor of the building, and then they have social housing flats above. So service users were on hand with respect to being able to access services that were on the ground floor, so to speak.
Now, seniors care we found was very much based on the biopsychosocial model. It was very person-centred out there. Lots of emphasis on voice, choice and control. There was emphasis on creating an environment to stimulate memory, emphasis on community care and participation within that community to enjoy the community as well as just existing within it. A lot of social care emphasis as well within the residential home, trying to get people out there and communicating with each other, not just outside but inside as well.
Something that our learners were very impressed with, as were we, was the positive and culturally appropriate language used out there. And I've just got a couple of examples here, some examples that we picked up when we had a chat last week with Sharon and Helen. Vulnerable individuals, they don't use that term, they use underserved populations. You know, it's putting that positive slant on the terminology. Seniors care instead of elderly care. Instead of individuals living on benefits, they're living with needs. Assisted living. And also it's the culturally appropriate language with Indigenous wellness to encourage participation in care services.
Now, when it comes to the future, the Wellbeing for Future Generations Act, there were similarities between Helen and Sharon's project. We noticed that we're both trying to create a resilient population, trying to harness the skills and talents of our own population and promoting the importance of our cultural identity, as well as similarities relating to the Social Services and Wellbeing Act.
So what next? It's quite hard to top that trip actually and the project. We want to develop this project and we are going to be very soon commencing a rural care academy within Coleg Ceredigion, and it's essentially to develop that culture of curiosity. So our rural care academy will be open to students enrolled on our health sciences courses already. It will be the same curriculum being delivered, so the exact same courses that we've always delivered that we mentioned at the beginning, but it's just a different method of delivery. So the Rural Care Academy, the focus will be on the challenges and the trends experienced within rural Wales in healthcare and social care, in training, how service delivery can overcome barriers to participation for service users, but we'll also collaborate with academic partnerships in Alberta, Canada, and we'll continue to develop those partnerships. Students will have the opportunities to understand issues in great detail, explore international models of best practice, and also the Academy will allow for dissemination of opportunities in academic and professional circles.
So, like Sarah said, the tool, well, it will be a tool for a new teaching method in health and social care within the context of rural healthcare delivery in rural Wales, creating a rural care academy for students studying health and social care and health sciences to increase knowledge around challenges and trends facing rural health and social care practices, to increase recruitment of the NHS Wales or Social Care Wales professionals post-qualification. The primary objective is to improve recruitment in both HE and FE institutions, to engage in health and social care training and to retain health and social care professionals post-registration within Wales. So what we've got set up for them this year is a long series of guest lectures and masterclasses. So I've had some of my previous Access students come in over the last couple of weeks to discuss with our current students what it was like in their academic journey from Access or health and social care diploma all the way through university to the point now where they have been employed by NHS Wales. So I've had a previous student from, well, Access, who's now a mental health nurse, and a previous Access student who's just qualified as a midwife, to inspire our current students to train, live and work in Wales. And they seem to be quite enthusiastic about it. Of course, attending rural care events. We've got some of our students here today, but they're not the Academy students. They will be tomorrow, but they hopefully will want to apply for the Academy next year. Hopefully we've inspired them. Wider sector engagement opportunities. We're hoping for another trip to Alberta. It's in the works. And lots of collaborative projects between ourselves, Helen and Sharon, and Norquest College and Alberta Health Services. So because of our wonderful digital technology now that we can have these wonderful workshops across the pond. So we've got lots of those things in the works for our Academy students.
Yeah, but one thing we've got to remember, yes, sounds fantastic, but the main principle obviously is to enhance student awareness of rural healthcare challenges, trends, and hopefully if our students move away from us, progress to universities further away, that they come back to work in the area. Absolutely. Or that they can stay in the area to train, hopefully. So our contact details are here. We do have a little bit of a request. Obviously, you're all an audience for us today.
We have you.
So if anybody would like to volunteer to come and meet the students, as part of the Academy, then you would be more than welcome.
Thank you. Thank you very much.
Thank you very much, Helen, Sharon, Sarah and Jennifer. I'll allow a quick time for questions because the rain's actually stopped, so we might be able to hear each other. Does anybody have any questions for the panelists from here or from Canada? Any online? Anna, I'd quite like to ask Sharon and Helen how they've enjoyed having our students from Ceredigion, as a Ceredigion resident, coming over to Canada. And do you do similar exchanges with other parts of the world?
Hi. Yes. Well, it's always exciting to have different parts of the world be able to talk to each other. Our role was kind of more behind the scenes, helping to get things set up for the students, and Sarah and Jen there. So our contact has been with them, and it's been just great to see the alignment between our work and their work that they're doing. We really see some opportunities around our competency framework feeding into maybe some of the work that they're doing.
Great, thank you. I'm in my past, I quite often quote the Northern Ontario School of Medicine when I'm getting very cross with certain things. About how you have to change things dramatically to get what you need in a rural setting. Mm-hmm. So it's great to hear from Canada. Thank you so much, both of you, and thank you, Sarah and Jennifer, as well. So I think it now falls to me to wind today's conference up. I would like to thank everybody who's attended. I would like to thank all the speakers. As usual, I'm going to refrain from doing a list, because if I do a list, I'll miss someone off and get into terrible trouble. I think today has been great. One of the really rewarding things about running conferences like this is the people who meet each other and later go on to do great things, like connections between Ceredigion and Canada and other such connections. So if I was you, Sarah and Jennifer, I wouldn't let anyone out the door till you've caught them on the way out, so you can grab them for what you need. Thank you very much, everybody. We would like you to vote on the posters before you go, and we need you to leave them. Where do you want them, Anna? If you could leave them on the table where you registered on your way out, that would be great. There is no hurry to depart. I believe we're not kicked out for a while out of the room. So if you haven't seen all the posters, please do. And I believe the weather forecast isn't great for the next hour. I've just been told by the locals. So take care when you're driving home, everyone. Thank you very much, one and all. And hopefully see some of you tomorrow. Thank you. Good night.